In this video, I will be completing my discussion on the diagnosis of pneumonia and then covering the rudimentaries of treatment as well as use of vaccines to prevent this potentially life-threatening disease. Gram stain serves as a real-time first-line diagnostic test for determining the etiology of a pneumonia. A sample should be obtained for all patients with a productive cough. This test differentiates between bacteria with thick peptidoglycan layers, which take up crystal violet dye and are gram-positive, and bacteria with thin peptidoglycan layers that fail to take up the dye and appear pink or gram-negative. Ideally, the sampling should be supervised by the caregiver to assure the sample comes from deep down in the lung after a deep cough. The adequacy of the sample can be assessed by the number of squamous epithelial cells, indicative of contamination by mouth contents. And 10 of these cells per low power field indicates excessive contamination of mouth flora. This type of sample should be discarded and not cultured. If the sample has over 25 neutrophils or PMNs per low power field and or bronchial epithelial cells, this suggests the sample is from the lungs and represents an adequate sample for culture. A sputum gram shade should be attained in all seriously ill patients requiring hospitalization. When reviewing a gram stain, it is important to first assess the adequacy of decolorization. If the nuclei of the cells are gram-positive, then the sample is not adequately decolorized. You want to look for a predominance of a single organism. This is likely to be the true pathogen. Determine if there is a predominance of PMNs. This suggests a bacterial pneumonia. If there is a predominance of mononuclear cells, this suggests mycoplasma, chlamydia, or a virus. This gram stain is perfectly decolorized and shows a predominance of gram-positive lancet-shaped diplococci, the classic appearance of strep pneumoniae. Never order a sputum culture without an accompanying gram stain, because you may end up culturing mouth flora. Also, you need to be aware that a positive sputum culture in the intubated patient often represents colonization rather than infection, a critical issue you need to understand. Unfortunately, sputum cultures are insensitive because mouth flora can overgrow the pathogen, making it difficult to identify. However, when a pathogen is cultured, its antibiotic sensitivities can be determined and correlated with the gram stain. 2 blood cultures should be drawn before antibiotics for all patients who are being admitted to the hospital with pneumonia, and cultures are positive in 1 to 16% of the time. 2 other blood tests that should be drawn to assess the severity of the illness are an arterial blood gas to assess the level of oxygenation and a peripheral white cell count. A high peripheral white blood cell count with band forms, young forms, suggests a serious bacterial pneumonia, and also may be helpful in differentiating bacteria from viral pneumonia. Bacteria usually are associated with a higher white blood cell count and a predominance of PMNs with band forms. Now that you understand how to diagnose pneumonia, let's return to our case of the 66-year-old man who was a smoker and presented with shortness of breath. Remember, in addition to shortness of breath, he had an elevated respiratory rate of 30, sinus tachycardia at 110 per minute, a PO2 of 60 on room air indicating hypoxia. He had a minimum sputum production, he had RALs in both lower lung fields, and appeared cyanotic. His sputum gram stain was unrevealing. And his chest x-ray shows an interstitial pattern. What is your diagnosis? Pneumonia, staphylococcal pneumonia, group A streptococcal pneumonia, influenza pneumonia, or Klebsiella pneumonia? We will discuss the answer in class. To summarize the diagnostic approach to pneumonia, remember to use the history, epidemiology, risk factors, pace of illness, key symptoms, and signs to narrow the differential. If you are considering pneumonia, always order a chest X-ray. Know the 5 patterns: lobar, bronchopneumonia, interstitial, abscess, and nodular. Gram stain is a first-line test and helps you to assess adequacy of sample, less than 10 epithelial cells, for culture, an inflammatory response, as well as prevailing pathogen. Blood cultures ×2 should be drawn for all admitted patients. Peripheral white cell count with differential helps you to differentiate bacterial from viral, and arterial blood gas is helpful for assessing the degree of hypoxia. Because bacteria double every 60 minutes, time is of the essence, and antibiotics should be initiated within 4 hours. Delays in therapy are known to increase mortality. The IDSA treatment guidelines recommend for hospitalized patients an intravenous third-generation cephalosporin, ceftriaxone being the most commonly prescribed. Recommendations also included a macrolide, azithromycin, or clarithromycin. However, more recent studies have demonstrated the addition of this antibiotic is of no benefit. For patients suitable for outpatient management, a macrolide is recommended, and the most commonly prescribed macrolide is azithromycin. The duration of antibiotic therapy depends on the patient's response. The trend is towards shorter antibiotic courses at this time. The minimum treatment for community-acquired pneumonia is 5 days. In general, if the patient's temperature is equal to or below 37.8 degrees centigrade, the heart rate is 100 per minute or lower, and the respiratory rate is less than or equal to 24 per minute, and systolic blood pressure is 90 millimeters mercury or higher, and the arterial saturation is 90% or higher, the patient is able to take medication, and nutrition by mouth, and mental status is normal, the patient can be switched to an oral medication, and antibiotics can be discontinued after 2 to 3 more days. What is the outcome of community-acquired pneumonia? Mortality ranges from 2 to 30%, and mortality is higher in patients 65 years of age or older, in patients with neoplastic disease, liver disease, congestive heart failure, and if they have suffered a cerebrovascular accident or have significant renal dysfunction. Given the potential severity of pneumonia, prevention is very important, and vaccination can not only prevent disease, but reduce disease severity. Influenza vaccine should be given annually to the elderly, pregnant women, the chronically ill, the very young, and school children. Pneumococcal vaccines are very safe and efficacious, and there are 2 of these now given, the 23-valent and the new conjugated 13-valent pneumococcal vaccine. They should be given for those who are over 65, those with chronic disease, asplenia, immunocompromised, and to alcoholics. Another very important preventive measure for those who are smokers is smoking cessation. Let me offer a final summary for the topic of community-acquired pneumonia. It is one of the most common infections in the elderly, nearly 1 per 100. I've reviewed the symptoms and signs of community-acquired pneumonia, emphasized that chest X-ray should be performed in all patients with suspected pneumonia, defined the usefulness of the sputum gram stain, the importance of ordering additional tests, including blood cultures in patients being considered for hospitalization, the importance of starting antibiotics within 4 hours, and I've emphasized the importance of preventative measures, vaccination for influenza and strep pneumoniae, and discontinuing smoking. I hope that this series of videos will help you to manage this life-threatening illness on the wards and in the hospital. Thank you.